Hello, let's get familiar with the approach. Hello, welcome to this topic where we'll be discussing approach to intestinal obstruction in the surgical department. Let's get started. By the end of this topic, you should be able to Hello, welcome to the topic approach to intestinal obstruction in the surgical module. By the end of this session, you should be able to define intestinal obstruction, outline the causes and risk factors of intestinal obstruction, understand the pathophysiology of intestinal obstruction, describe the common clinical findings you'd expect to see in a patient who has intestinal obstruction, and finally, outline a basic approach to a patient with intestinal obstruction, or also called IO. So, what is intestinal obstruction? An acute intestinal obstruction occurs when there is an interruption in the flow of intestinal contents. Intestinal obstruction is most commonly caused by intra-abdominal adhesions, malignancy, or intestinal herniations. Adhesions, malignancy, or herniation of the bowel causes constriction of the bowel lumen, leading to obstruction of the flow of gut contents, which hinders the exit of the content. This interruption can occur at any point along the length of the gastrointestinal tract, and clinical symptoms are often based on the level of obstruction. The area before the point of obstruction, the intestinal tract, dilates as it fills with intestinal secretions and swallowed air. Failure of intestinal contents to pass through the intestinal tract leads to a halted bowel and gas movement. Ongoing dilation of the intestine increases luminal pressures, and when luminal pressures exceed venous pressures, loss of venous drainage causes increasing edema and hyperemia of the bowel. This eventually may lead to compromised arterial flow to the bowel, causing ischemia, necrosis, or perforation. Next, let's take a look at the symptoms. Clinical presentation generally includes nausea, emesis or vomiting, colicky abdominal pain, and a failure to pass flatus or bowel movement. Besides that, patients should be asked about their history of abdominal neoplasia, hernia, or hernia repair, and inflammatory bowel disease because these conditions increase the risk of obstruction. In terms of general examination, you may find signs of dehydration such as tachycardia, hypovolemia or hypotension, or dry mucous membranes. On abdominal exam, you will notice abdominal distension, diffuse abdominal tenderness, and tympany to percussion. Auscultation in patients with early obstruction reveals high-pitched bowel sounds, whereas those with late obstruction may present with minimal or even absent bowel sounds as the intestinal tract becomes hypotonic. On digital rectal examination, there may be collapsed empty rectum, incomplete bowel obstruction, or impacted feces. Do bear in mind that distal obstruction allow for a greater intestinal reservoir with pain and distension more marked than emesis, whereas patients with proximal obstruction may have minimal abdominal distension but marked emesis or vomiting. Moving on to imaging. Radiological imaging can confirm the diagnosis and also serves as a useful adjunctive investigation when the diagnosis is less certain. The initial evaluation of patients with clinical signs and symptoms of intestinal obstruction should include plain upright abdominal X-ray. A radiograph or X-ray can quickly determine if the intestinal perforation has occurred. Free air can be seen above the liver in upright films or left lateral decubitus films. In patients with small bowel obstruction, supine views show dilation of the multiple loops of small bowel with paucity of air in the large bowel. Those with large bowel obstruction may have dilation of the colon with decompressed small bowel in the setting of a competent ileocecal valve. An upright or lateral decubitus film may show laddering air fluid levels. In patients with small bowel obstruction, supine views show dilation of multiple loops of small bowel with a paucity of air in the large bowel. And those with large bowel obstruction may have dilation of the colon with decompressed small bowel in the setting of a competent ileocecal valve. CT is appropriate for further evaluation of patients with suspected intestinal obstruction in whom clinical examination and radiography do not yield a definitive diagnosis. CT can identify emergent causes of intestinal obstruction such as volvulus or intestinal strangulation. CT findings in patients with intestinal obstruction include dilated loops of bowel proximal to the site of obstruction with distally decompressed bowel. The presence of a discrete transition point helps guide operative planning. A non-contrast CT is recommended if the index of suspicion is high or if suspicion persists despite negative radiography. Next, what can you order for lab tests? Lab evaluation of patients with suspected obstruction should include a full blood count and metabolic panel. You may notice elevated white cell count if intestinal bacteria translocation into the bloodstream occurs, causing systemic inflammatory response syndrome or sepsis. Additionally, hemoglobin and hematocrit levels may be increased due to dehydration. Elevated blood urea nitrogen levels are also consistent with dehydration. Hypokalemia or hypochloremic metabolic acidosis may be noted in patients with severe emesis. However, the development of metabolic acidosis, especially in patients with increasing serum lactate, may indicate bowel ischemia. Next, let's take a look at the management. Management of intestinal obstruction is directed at correcting physiological derangements caused by the obstruction, bowel rest, and removing the source of obstruction. Management of uncomplicated obstruction includes intravenous fluid resuscitation with isotonic fluid for metabolic derangement, the use of bladder catheter to closely monitor urine output if it's minimum, requiring gauging the adequacy of resuscitation. Other invasive measures include arterial canalization or central venous pressure monitoring. Antibiotics are used to treat intestinal growth of bacteria and translocation across the bowel wall. Aggressive replacement of electrolytes is recommended after adequate renal function is confirmed. Intestinal decompression as well as bowel rest are among other important measures to manage intestinal obstruction. Let's take a look at surgical management. Peritonitis or clinical instability or an unexplained leukocytosis with acidosis are concerning for abdominal sepsis, intestinal ischemia, or perforation, and these findings mandate immediate surgical exploration. Stable patients with a history of abdominal malignancy or high suspicion for malignancy can be thoroughly evaluated for optimal surgical planning. Any evidence of vascular compromise or perforation or failure to resolve with adequate bowel decompression is an indication for immediate surgical intervention. Now, to summarize, intestinal obstruction is defined as a significant mechanical impairment or complete arrest of the passage of content through the intestine due to the pathology that causes the obstruction of the bowel. The cardinal signs of intestinal obstruction include abdominal pain, vomiting, constipation, abdominal distension, and decreased bowel sounds, regardless of the underlying etiology. Diagnosis is clinical and confirmed by abdominal x-rays. Prolonged obstruction can cause bowel ischemia, infarction, and perforation. Nasogastric suction and IV fluids should be administered prior to surgical repair, and surgery can be considered if non-operative management renders no positive outcomes. We have come to the end of this topic. Thank you for your time.